So the task given to me is to discuss the MR case, and these are the headings under which I am supposed to be talking. That is 60-year-old lady, and she has no comorbidities. She has some symptoms. She has moderately severe MR. The dimensions are end systolic 39 and EF 65, LAVI 58, PA pressures 40, and the management. Now, the thing is, someone who has made this case has put a lot of thought that I can make out, because the cutoffs for the LAVI, PA pressures, and the LV dimensions are slightly less than what are the cutoff values given by the guidelines. So the decision, we'll start it reverse way. The decision of intervention in primary MR, as we know, depends in the class 1 indications are all depend upon the symptoms, and obviously feasibility of repair where you have got a lower threshold, and lastly the LV remodeling where you go for the end systolic dimensions. Generally it is taken as 40 millimeters. But let me tell you that these are very crude guidelines. We have to go ahead of this. One size doesn't fit all, and the EF always is 60% or less. And the two indications are to look for the atrial fibrillation, PA pressures going high, because that is the brunt of MR onto the LA and pulmonary circulation, and the LA remodeling 60 ml. But let me tell you that these cutoffs are not sacrosanct, okay, and I will prove it that way. But most important is the symptoms, and you should always have an objective evaluation of the exercise capacity. Don't go by the history. So the most important, put him on the treadmill and actually see for yourself. And if you have the more objective way of looking at it by doing a cardiopulmonary exercise test, then you can get all these kinds of graphs, and most important, you will be able to calculate the peak VO2. And remember, the peak VO2, anything going below 15 ml per kg per minute, actually puts the patient at a high risk. For women, the cutoffs are slightly lower. So now we are talking about the gender here. And now is the time of personalized medicine, and we have to be very sensitive about the gender in valvular heart disease. Because in the last 4 or 5 years, the literature is replete with so many findings that the male and female have a different LV remodeling or LA remodeling in various valvular heart disease, including aortic stenosis and mitral regurgitation. So that is why I said that we are talking about a lady, okay, and the cutoffs should not be sacrosanct. So let us look at this particular study, which comes from the Europe, looking at the primary mitral regurgitation, and they looked at the male and female with the same regurgitation fraction. Okay, the females are with the red bar, with the same regurgitation fraction. And then they looked at the disease burden. So what is the disease burden? What is the effect of the MR? What is your NYHA class? What is your LA dilatation? And what is your pH? Because that's the brunt of the disease of the MR. So what they find is that women, the group had more elderly women. The red bars are the women. They are more symptomatic, and they had a much higher LA volumes. So probably women are sent little late for the mitral valve surgery. That is important, and their LA dilatation is much more than the male. That is first thing. Secondly, they also find that the females had a higher pH despite having the same regurgitation fraction. So that means with the same regurgitation fraction, females are showing more disease burden in terms of symptoms, pH and LA volumes. Okay, the same thing looking at the MR quantification values. Now, despite having the higher disease burden, they had a lower regurgitation volumes. Okay, they had smaller EROS. They had smaller regurgitation volume both by echo and MRI, and also they had lesser LV dilatation. So that means just taking one value of cutoff for the end systolic dimension or the volume is not good. We are progressing towards individualized medicines, and now we have to look at the gender differences. This is true even in aortic stenosis, because female get less hypertrophy as compared to the male. So again, looking at the MR quantification values, lesser women had actually the end systolic dimensions more than 40 millimeters in the same group. That means the LV doesn't dilate so much in women. And most important, this graph, if you look at the X, X, it is the CMR MR regurgitation fraction, and then on the Y you have got the LV volume. For every regurgitation fraction, you will find that the women with the red line had a lower LV end diastolic volumes. Okay, so this is very important. Second thing is that if you look again at this disease burden by the LA volume, RV pressure and NYHA class, and why we are calling this as disease burden, because these three things decide about your post MVR status or the CV events or mortality. So that is why this is called as the disease burden in mitral regurgitation. The only thing that correlates with disease burden is neither EROA, neither regurgitation volume, but only regurgitation fraction. So that means when we are comparing the male and female, I think it is better to go by regurgitation fraction. And this is very true for secondary MR and also now true for primary MR. Because women are going to have smaller regurgitation EROS, smaller regurgitation volume, but higher disease burden. So also if you are, so that is why probably you may need a lower EROA, lower regurgitation volume cutoffs for the women. So we'll not get bind or we shouldn't take the slavery of the guidelines, but start thinking differently. This is actually a much larger study which comes from the Cleveland Clinic and the Texas group, and this is a very large data set of women and men, almost 4,500 with mitral regurgitation, and this is very eye-opening. If you look at the hazards ratio for death, and on the and the x-axis, if you look at the LV end systolic dimension, and women in the red lines, you will find that actually for the women, the inflection point for increase in the heart rate comes much below 40 millimeters, okay, and it is at 36 millimeters, okay, and for the male it comes after 40 millimeters. So again, that is what I was telling, that whoever has written this case, he has put the end systolic dimension in this lady between 36 to 40, okay, for challenging the scenario. So remember that the women start having the higher HRs for the death at much lower cutoffs in the MR. And so also, and this difference is not negated by indexing into body surface area. And so if you look at the index LV end diastolic dimensions, then for women it is 18 millimeter per meter square, and for male it is 21. So index into body surface area doesn't take into account the smaller body surface area of the women. Women as a gender behave differently both in MR and also in aortic stenosis, that you should be thinking in the TAVR. And so also if you look at the ejection fraction, there is another surprise. In women, as the ejection fraction just falls below 60, the mortality stutters starts rising very sharply as compared to the male. Okay, male take its much longer time, okay, when the EF drops in the mitral regurgitation to increase the hazards ratio for the death or CV events. So that means for women having an ejection fraction even closer to 60%, you have to be alerted. Okay, and the guidelines have to do a lot of work to be gender sensitive. Okay, then the concept now in the valvular heart disease is now not just to quantify the valvular heart disease, the stenosis or regurgitation volumes or so and so forth, but look at the myocardial health of left atrium or left ventricle. So how do we look at it? By the echo, obviously with the GLS for the LV, and obviously for the strain analysis of the left atrium. And there are lots of paper in the GLS in the mitral regurgitation, but let me show you only one. The red bars tell you where the GLS is still above 18%, that means obviously minus value less than 18. And you would see that actually the post-operative ejection fraction is much better preserved when your GLS is above 18%. And so also the LV reverse remodeling after MVR is much better when your GLS is less than 18% as compared to those where the GLS was less than 18% shown by the green line. So also you can look at the health of the LV myocardium also by the MRI, okay? And what do you look in the MRI? You look at the extracellular volume expansion, which tells you about the interstitial fibrosis, okay? And also the death of the myocytes, which is replacement fibrosis, which is seen by the late gadolinium enhancements. Okay, so there are ways to calculate this extracellular volume which is quite accurate and reproducible, and normal extracellular volume would be between 20 to 25%, and the replacement is seen by the white thing of the Lg over the black myocardium. Now the studies have shown that if you look at the degenerative mitral regurgitation, patients with MVP show more myocardial replacement with fibrosis, and that is why they are probably more arrhythmogenic, because they create that substrate, while non-MVP related MRs will hardly show any Lg. However, both of them, as the EF goes on increasing, they will start showing you more and more interstitial fibrosis. And remember, this interstitial fibrosis is reversible. When you operate, this interstitial fibrosis can still reverse, but the replacement fibrosis doesn't get reversed after mitral wall replacement. However, still this extracellular volume expansion is important, because if you have got a less extracellular volume expansion, that is less interstitial fibrosis, you have better post-operative EFs and the lesser LV end systolic volumes, okay, as compared to when you have got a more interstitial fibrosis. So that means looking at the myocardial health, looking away from the valve, is the key in the management of valvular heart disease. Okay, and rather this study is very interesting, coming from this group from Texas, that if you have got the same regurgitation fraction of between 30 to 50% of MR, but if your extracellular volume is more than 30%, you suddenly have a lesser event-free survival, okay, for the same level of regurgitation fraction between 30 to 50%. So that means ECV can be looked at, and another biomarker, okay, which further risk stratifies for the same level of regurgitation fractions or regurgitation volumes. How do we look at the LA myocardial health? Obviously, we should look at the LA volumes, which is very simple, and also at the LA strains. Okay, and we know that we have to go a little para-axially to get the longest axis of the LA, because longest axis of the LA is not parallel to the longest axis of LV, and then get the biplane measurements. Okay, now this is another large study coming from the Mayo Clinic with collaboration with the French group. They looked at this the LA enlargement in the population, and obviously patients with the severe MR are going to have larger LA volumes. But what is interesting is the long-term mortality with vis-a-vis the LA volumes. Whether you are in sinus rhythm or you are in atrial fibrillation, you would find that much below the, or somewhere around 40 ml per meter square, okay, the hazards for death and the death suddenly starts rising. So though the guidelines tell you about 60 ml as your cutoffs, remember from 40 to 60, the hazards ratio for death keep on increasing on medical management. So also, whether you are below 40 ml, you are between 40 to 60 or above 60 ml per meter square, there is a linear relation in the survival, okay. Larger the LA, worse is the survival, okay. So we should not just go by those cutoff values by these guidelines, and we should know that this is a continuous variable, okay. So anything going above 40 ml per meter square LA volumes in the MR, the hazards ratio for the death on medical treatment goes on rising, okay. So also about the LA reservoir strain, which is most studied. Of course, the LA reservoir strain will not completely depend upon MR. It depends upon the LA relaxation, the LA chamber stiffness, and also LVGLS. And this is how you look at the LA strain. This is the reservoir strain that you look for. And also you look at the strain rates, and this is how you measure the strain rates. But what is interesting is that there is one Korean study by Dr. JKO looking at the degenerative MRs and the cutoff value of LA reservoir strain, and LA reservoir strain below 23%, which cutoff has been taken for the diastolic dysfunction assessment in the patients with non-valvular heart disease. Now here with the patients with the MR also, this 23% is a cutoff beyond which, that means the LA strain below 23%, there was an excess all-cause mortality, heart failure and heart failure hospitalization after mitral valve regurgitation. However, this cutoff is much lower for the secondary MR, and this The work comes from Netherlands, and they show that something below 9%, the hazard ratio go on steeply rising in patients with secondary mitral regurgitation. And remember, this LA stiffness goes on increasing. The LA stiffness is E by E prime divided by the LA strain. And you would see that it goes on increasing from the degenerative MR, whether it is mild to severe, and also secondary MR, whether it is mild to severe. The LA stiffness goes on increasing because obviously the mechanism of degenerative MR and secondary MR is different. And they also behave differently with exercise. Okay, so whenever we are looking at the mitral regurgitation, two things are important. You have to look at the mechanism of MR and quantification of MR, and obviously the remodeling of LALV, which we have already discussed. So let us look at the mechanism of MR. There is nothing better than the echo, and especially the transesophageal echo, and especially with the 3D. No imaging modality can compete with the echo for knowing the mechanism of mitral regurgitation. Okay. And as we know, the Carpentier classification, that either you have got the annular dilatation or leaflet perforation, which is type 1, or you have got excess mobility of the leaflet. When the leaflet edge crosses the annulus, you call it as prolapse. And when the edge starts pointing towards the LA, you call it as the flail or rupture. And 3 is obviously when you have got the mitral valve restriction to the movement, whether it is during diastole systole like in the rheumatic, or only during systole like in secondary MR, which is 3B. However, you have to look at the mitral wall, and this is the cartoon of the mitral wall, and these are the transthoracic ones that I have shown it in the yellow, and the white ones are the T planes. And then these are the T planes to look at the various commissures. And you can go through the Indian Academy of Echo, the guidelines to look at the transesophageal echo of the mitral wall, and you will find this picture there. Now, how to know the mechanism of MR? I always like to divide the left atrium into superior and inferior chamber. The jets which are directed in the superior chamber are because of the prolapse or frail of the posterior mitral leaflet, while those which are directed in the inferior part of the chamber are because of the prolapse or frail of the anterior leaflet. So also you divide the cavity into the medial, mid and lateral region, and those jets which are directed towards the interatrial septum are because of the lateral commissure problem, and those which are directed towards the LA appendage are because of the cuspal prolapse or leaflets which come from the medial commissures. Okay, and we'll just look at quickly we'll go through certain cases. And this is a posterolaterally directed jet on the transthoracic echo. And on the transesophageal echo, you look at the same thing. You have got a posterolaterally directed jet. The bicom view looks good, but in the long axis view, you see the flail A2 in the 120 to 135 degrees. And when you go on to the 3D, it becomes very, very easy to pinpoint the A2, because here you are orienting into the surgeon's view. This is the aortic root, which is at 12 o'clock, LA appendage at around 10 o'clock, interatrial septum at 3 o'clock. And you can see the AML with the ruptured chordae in the center. And so this is the mechanism is flail A2. Look at the second patient, and you have got the jet directed anteriorly both on the T and the transthoracic echo, and 3D makes it very easy because it gives you the perspective, and you can see the P2 because this is P1, this is P2, and this is P3. This is lateral commissure, this is medial commissure, and you can look at the P2 prolapse into the left atrium, telling you that this is the mechanism. So also you can look it from the LV aspect. And this is another patient with little complex. You have got the anteriorly directed jet, and this is the bicom view, and you can see the jet is directed towards the LA appendage. Okay, something coming from the medial commissure. The things become very simple when you look at the 3D, and you can look at that. This is the P3 which is prolapsing, which is prolapsing into the left atrium with a flail leaflet there. So this is the P3 prolapse. The jet is coming from the medial commissure. And you can also get the jet which is directed in the anterior chamber and towards the LA appendage. So telling you that it is the P3 prolapse. Okay. So this is the P3 prolapse. Now this is another one with a a little more difficult one, you can see as if the leaflets are not coapting together, a very dilated mitral annulus, but this is a very young patient, very unlikely to have secondary mitral regurgitation. But there are areas where the AML and PML are hardly touching with each other, okay? But put it on in the 3D and it is so easy to make out that there is a big cleft between P2 and P3 here, okay? Between P2 and P3 you see there is a large cleft. And you know the cleft has to reach, because there are always some indentation at the P1, P2, P2, P3 junctions. But if the indentation goes all the way down to the annulus, you know that this is the real cleft. And these clefts are, and you can see the same cleft from the LV aspect also between the P2 and the P3. So this is the mechanism of cleft LM, and whenever you are cutting through the cleft, you are finding that the leaflets are not coapting. So this perspective of 3D is unmatched, because in real time you see the mitral wall, which even the surgeon doesn't see, because he sees all that flaccid. And this is much more complex wall, and I don't think there are 2-3 jets, and I don't think you can make out with that simple classification, you can really make out about any prolapse segment there. Okay, so we'll put this patient again into the 3D, and actually you will see that there is a P2, P3, both are showing a flail leaflet there, and not only there is a P2, P3 prolapse, but along with that there is a cleft between the cleft between the P2 and P1. So there was a P2 and P3 P1 and P2 prolapse along with a cleft there. Okay. Now, why we should be knowing about the mechanism of MR? For the simple reason that the flail leaflet doesn't behave well. Okay. But let me reiterate again this confusion about billowing of the leaflet, prolapse of the leaflet, and the flail leaflet. Now remember, when the leaflet body crosses the annulus towards the LA, it is billowing. But when the edge of the leaflet goes below the annulus, okay, it is a prolapse. And the moment the edge of the leaflet starts pointing towards the left atrium, that's the flail thing. Okay. And obviously, as you know, that the annulus has got a saddle shape. So whenever you are seeing these in the long axis views, you know that the whole thing is going much below the lowest points of the annulus. Okay. However, you remember that flail leaflets don't behave well. And this is a paper by Dr. Ling many years back from when he was working in Mayo. And they showed that in 10 years, either the patient, they are dead, or they have got wall replacement, or they are in heart failure if you have got a flail leaflet. So they behave differently than the regular degenerative mitral regurgitation. A quick about the quantification of the MR. From the MR AAC guidelines, we have got looking at the structure, looking at the qualitative ways, and then looking at some semi-quantitative ways of the vena contracta and 3D VCA and the pulmonary vein flow, and then there are quantifications using ERO and regurgitation volume and regurgitation fraction. Okay, now let me lastly touch with my 2 slides. I got 1.5 minutes there. That do we have any other standard of measurement of regurgitation volume and regurgitation fraction? And as we know that this is the AAC algorithm, that if you have got 4 out of 6 in this, then you definitely have very severe mitral regurgitation. But this concept has been challenged by the studies coming from cardiac MRI, because in cardiac MRI you look at the LV volumes, stroke volumes, and you subtract the aortic forward flow, and that is how you get the regurgitation volume. And actually the correlation between the MR and the regurgitation volume on CMR is not that great. The 6 parameters I showed you on the AAC, which tell you definite severe MR, actually whether the jet is eccentric or central jet, it is only in 56% to 33% that the CMR tells you about severity of MR, and grade 3 in another 17% and 19%. So that means there is a large amount of discrepancy between the MR regurgitation volumes or the AAC algorithm for severe mitral regurgitation and the mitral and the regurgitation volumes and fractions measured by the CMR, and this needs to be resolved. And not only even for the individual parameters of pulmonary wall systolic reversal, flail leaflet, vena contracta, jet area, PISA, and EDV, you can see that the CMR severity as shown by the red part of the graph, that's the only concurrence between the CMR and the echo regurgitation volume. So I think that's the think that we have to be very careful in our measurements with the echo. Should reduce the inter-study variability, interpersonal variability, and should always assess our results with at least one study of MRI to assess the veracity of our measurements. Thank you.